Hello everyone, can you hear me? Welcome to Nursing Grand Rounds, and we're going to start our presentation in just a moment. With me I have Paula Gold, and then sitting over here is Kim Lawrence. They're both going to be able to answer your questions at the end of the meeting, but Paula will be presenting the PowerPoint we have on kidney transplantation and our 42 years that we have been performing. Yeah, we saw all the flags about a month ago, I think it was. And so I'm going to have Paula start with our presentation. Thank you all for coming.
Good afternoon. It's my pleasure to speak to you today regarding kidney transplantation. We've been doing that here at St. Joseph for 42 years, and we have a nice track record of excellence that we are very proud of. Our objectives today are to identify treatment options for renal failure, discuss selection criteria for transplantation, provide an overview of the transplant evaluation process, provide an overview of the kidney transplant surgical procedure, review post-transplant medical management, signs and symptoms of transplant rejection, and provide examples of and the importance of patient education. And then if you have questions that we can discuss ways to strengthen relationships between the inpatient units and the transplant team. So the first successful kidney transplant was done in 1954 at the Brigham on the East Coast, but here at St. Joseph we started in 1973. We've been doing transplantation ever since. 2013 marked our 40th year, and recently you probably saw 1,000 green flags. We've done 1,002 kidney transplants thus far. Our outcomes are among the best in the nation, and we're very proud of that. Here you can see our transplant patient survival. We have the 1 and 3 years. Now, every transplant center in the United States is required to report their outcomes. We report them to the SRTR, which stands for Scientific Registry for Transplant Recipients, and so you can go to this website and see the outcomes of any transplant center in the United States. Currently, there's about 246 transplant centers in the United States. If you want to see how UCLA was doing or how the University of Wisconsin was doing, you can go to this website. But you can see here we've divided our sources of kidneys. We have the deceased donor and the live donor. We have 100% patient survival. This is the United States survival overall, and our 3 years is equally good. The time frame that's being reported is from July 1, 2011 through December 31, 2013. This report comes out twice a year, and it's a rolling 2.5-year report. So the next time will be moved over by 6 months. Our graft survival, our kidney survival, you can see that as well. We've got 100% graft survival compared to the national average, and our 3 years is equally good. This is also the same reporting time frame. So who are our transplant patients? Well, there's anybody who has chronic renal failure. These are patients who have diabetes, glomerulonephritis, hypertension, obstructive neuropathy, polycystic kidney disease, congenital anomalies, autoimmune diseases like lupus, medication toxicities like from lithium if you're a patient who takes lithium. There are patients who are pre-dialysis. In order for us to put you on our national wait list, you have to have a GFR, or glomerular filtration rate, 20 mLs or less. These are patients who are also on dialysis. They're either on peritoneal or hemodialysis. And we also have patients who are needing retransplant, who have lost their previous transplant. Chronic kidney disease, you can see that there are 5 classifications for the chronic, 5 stages of chronic kidney disease here. We deal mostly in the class 4 and class 5. We won't see patients in class 2, but it would be nice if the nephrologists could start sending patients to transplant centers to begin their evaluation in stage 3. So why do we do transplantations? After all, everybody can have dialysis in the United States. It is life-saving, but it only replaces 12% of kidney function. Nationally, there's over 400,000 patients that are on dialysis, and over 90,000 patients are waiting on a national kidney transplant list. That transplant list expands 3,000 to 4,000 per year, but the number of donors remains static. There's only about 10,000 transplants from deceased donors, which means there are 5,000 deceased donors per year, and then 6,000 transplants from living donors. 10 people die every day while waiting on a transplant list for an organ. The cost of transplantation is so much better than the cost of kidney dialysis. So in the middle here is hemodialysis. So the slide's a little bit old, but this is, each block is a year. So it used to be about $75,000, it's about $86,000 a year now to do dialysis. And the transplant here was just under $100,000. Right now it's $100,000. These light green ones is the functioning graft, which is medication. Here is the cost of a transplant, the cost of trying to treat a graft that's failing, and then the patient returning to dialysis. So easily by year 2, we break even with dialysis. And if we can keep the graft going, it's significant cost savings to the federal government. Most patients who have kidney failure are covered under Medicare's ESRD program. It is only a fraction of their total Medicare population, but it consumes billions of dollars of money. And really the most important reason to do transplantation is because we increase the life expectancy of patients. Here, back in 1999, Dr. Wolf looked at patients who were candidates for transplant, for their first transplant. And on average, he said that if you stayed on dialysis, you'd live 10 years. And then it's different based on your age and if you have diabetes or not. But if we gave you a transplant, we doubled your life expectancy, and it's most dramatic when you see it in the diabetic population here. So doing a transplant is more cost effective. We also think it improves their quality of life. So the big question is transplant the right treatment, and will it make the patient better? Now, there are over 400,000 patients on dialysis, but only 1 in 5 is really a candidate for transplant. We've learned over time that if we transplanted everybody, we would kill them. So we have to be very select about, is the treatment right for them or not? So this is a question that is paramount across the United States. So United Network for Organ Sharing, or UNOS, was developed by Department of Health and Human Services. And it brings together surgeons, coordinators, organ procurement agencies, histocompatibility labs, ethicists, the public, to make policy, to provide education for patients regarding giving transplants to as many people as possible and distributing organs in an equitable manner. So the pre-transplant workup, what does that mean? Well, the patient and family come to an educational program. We tell them about transplantation. There are risks to having a transplant, and there are benefits to having a transplant. They meet with the transplant surgeon who identifies medical and surgical risks. We try and correct any problems before we do the transplant. So if a patient has a coronary occlusion and they need a bypass graft, we do the bypass surgery before we do the transplant. Then meet with the transplant social worker to identify any psychosocial risk factors and correct any problems before transplant. So if the patient is moving, it might be a good idea that the patient finish their move before we do a transplant. The transplant coordinator is kind of the captain of this whole deal here. We guide the patient through their history and physical. They have numerous blood tests. There's a series of other tests like x-rays, EKGs. We help the patients get to the GYN for their pap and mammogram if they're a female, colonoscopy if they need to do that as well. We get the patients to the various consultants, the cardiologist, the gastroenterologist, gynecologist, the dentist even. The patient will also meet with the transplant dietitian and the transplant financial coordinator. We screen for active infection. We do serologies. Have they had CMV? Have they had Epstein-Barr? We look for other sources of infections like the urine. Is the urine infected? Is it chronically infected? Is there a diabetic foot ulcer? Is there tuberculosis? We screen for cancer, PAPs, mammograms, PSA for men, colonoscopy for everyone that's age 50 or older or has some type of significant history. We screen for clotting factors. Does the patient have factor V latent? Are they positive on their anticardiolipin? We look at cardiac risks as well. Are they diabetic? Do they have hypertension? Do they have symptoms or a history of having cardiac issues? Are they 50 or older? Is there a pulmonary risk? Do they smoke? Is there a vascular risk? Are the iliac vessels patent? We've got to have a place to hook that kidney up, otherwise it won't work. Are there femoral and pedal pulses? Do we have to worry about salvaging extremities? Psychosocial risk. Is there support by a family or friend? Is there transportation? Will the patient be adherent? If they're chronically missing dialysis, they're probably not going to be adherent post. Do they understand the process, both pre and post? Are there psychiatric disorders like depression, or are they bipolar? What about the nutritional risk? Are they underweight? Are they overweight? Are they deconditioned? Can they get themselves out of a wheelchair up onto the exam table or out of a bed and start ambulating? If they can't do those things, then they're at greater risk. And then financial screening. Do they have a share of cost? Is their insurance intact? Or they are able to get medication? So we have a whole team to answer the question here. You can see the patient and the family are in the center. We have the transplant surgeon, a nephrologist, primary physician, our social worker, our financial coordinator, our dietitian, and the coordinators. Consultants as needed. Once the patient has gone through the evaluation process, they're taken to a transplant selection committee where it's composed of the same people that you saw on the team here. And we review the patient in detail. If the patient meets selection criteria, their name is added to the wait list, and then they're on the wait list for a deceased donor. If they happen to have somebody who could potentially be a live donor for them, then we can start the evaluation of the live donor. So the sources of kidneys, we've got two. There's a deceased donor kidney or a live donor kidney. Deceased donors are standard criteria donors, or what they call expanded criteria. That's been changed a little bit now, but an expanded criteria donor is an older donor, somebody who's over the age of 50, has hypertension, maybe an elevated creatinine. For some people, that kind of donor is appropriate for them. But patients wait years for kidneys, so we pretty much get one shot. An annual update is needed, and patients will die at the rate of 7% per year on the wait list. Live donors can be related or unrelated. They can be incompatible donors. Since we do an incompatible transplant, we actually transplant across blood groups. That's a very risky transplant, but if the titers are low enough, we will do that. The good thing about the live donor, it is a planned surgery. It's not like a cadaver or a deceased donor transplant where that comes anytime they want to, but a live donor transplant is planned. We need to check out compatibility. Do we have the right blood type? HLA stands for tissue typing, human leukocyte antigens, and then we cross-match against the donor. Are we going to have problems with that? We also look for calculated panel reactive antibodies. Okay, so for blood type compatibility, you can see if you're blood type O, you only get an O. If you're AB or AB, you get O or A or B, and if you're AB, you can have them all. If you're on the deceased donor wait list, O's will only go to O's because they wait a very long time. AB has the shortest amount of waiting time. We cross-match by mixing the recipient's blood with the donor's blood. If it is a positive cross-match, we cannot move forward because it means that as soon as the vascular clamps are released, the body will recognize the antigens and kill off the kidney. We need a negative cross-match in order to proceed with transplant. Now, the deceased donors are allocated on a point system. So depending upon how long you've been on the wait list and your blood type, you are re-ranked every time a donor becomes available. So the donor's blood type is entered into the computer at UNOS. If you're a pediatric status, which means you're 18 or younger, or you're an adult. Are you waiting for an extra renal organ, which means you need a liver or a heart to go with your kidney, or a pancreas? How much waiting time do you have? What is the cross-match? And the tissue typing, whether you match or mismatch the donor. So we've got two kinds of donors. We have the deceased donor. These are the ones you normally see in the ICU. They are legally brain dead. They have to do some type of trauma or event. So they could have had a stroke, which is most common, or they could have ruptured an aneurysm. But we have challenges with them. Not all deceased donor transplants work right away. We have 50% chance that we will have delayed graft function, which means the patient will wake up from surgery and still have to have dialysis. And it may take anywhere from 2 days to several weeks before the kidney wakes up and starts to function. But deceased donors have other problems. There's a severe shortage. There's a 7% death rate while waiting on the wait list for a deceased donor organ. And the average wait time is 5 to 10 years and can be as long as 8 to 12 depending upon the blood type. In our service area, if you're blood type B, you will wait close to 12 years for your first organ offer. So it behooves the patient to have a live donor if that's at all possible. The second kind of deceased donor is a donation that occurs after cardiac death. There is severe brain injury, but the patient is not brain dead. The family elects to withdraw life support, and when that happens, the heart stops, and then the patient is declared deceased, and the organs are recovered if the family has recovered and has consented to organ recovery. Now, for live donors, we have two kinds of live donors. Just like we have two kinds of deceased donors, there's the blood relative, so your parents, your children, your siblings make up the live donor, the blood relatives. The emotionally related would be the spouses, best friends, step-parents, extended family, like your aunt or uncle, somebody who would have an investment in donating an organ to you. There's no maximum age, but generally they must be 60 or younger, and a minimum of 18 years of age. The live donor kidney evaluation, our number one priority is the safety of the donor. We must not compromise the donor in any way, and the donor cannot be exploited. So there's a lot of investigation about why the donor is donating. Are they being paid? Are they being coerced to be a donor? The evaluation may be as intensive as the recipient's evaluation. Much of it is the same. Progression of the donor evaluation depends on the donor's availability. Can I come any day and every day? You can do that. We can get you done quickly. If I can only come every Wednesday after 3, that's going to be a long process getting you done. And what's your health as a donor? So a lot of patients come forward to be donors, but we find out they're really not so healthy, as you see America is aging, and many of us are a little overweight, which means we might have a little bit of hypertension. And during a donor evaluation, we may uncover diseases that the donor doesn't even know they have. Confidentiality of the donor's medical information is our utmost importance. It is not shared with the recipient in any way. The donor may stop their evaluation at any time, and if they choose to do that, all the intended recipient is told that the donor cannot proceed. So we screen the live donor for pre-existing factors. Do they have diabetes? Do they have hypertension? They'll wear a 24-hour monitor to determine that. What's their BMI? Are they overweight? Are they underweight? Do they have kidney stones or recurrent urinary tract infections? What if they have cancer? What if their PHS stands for public health high risk? Do they use any drugs? Do they have sex with drugs? Do they have sex with multiple partners? And so they're at risk. We screen our donors for ABO. We have to have the right blood type. For tissue typing, do they match the intended recipient in any way? They don't need to match, but it'd be nice if they did. And then what is the cross match? That's very important. We can't proceed if the cross match is positive. We examine all major organ systems. There's a general health screen. There's blood tests, so the general chemistry, lipids, fasting glucose, urine tests, 24-hour blood pressure monitoring. We do tests to determine their kidney function. There's a 24-hour urine collection for creatinine clearance, for protein and albumin excretion. They get a chest x-ray, they get an EKG. This is all kinds of stuff that you see on the recipient side. The live donor has to consult with the transplant social worker and a donor advocate. They have to consult with the transplant medical director, so that would be Dr. Ruzix. They see the donor nephrologist, our donor surgeon, and any consultants that might be needed. So if it was a female, we needed for them to see a gynecologist, it would be that. If they need to go see the cardiologist, it would be that as well. Finally, a CT angiogram is done to visualize the renal blood vessels, and we prefer to take the left kidney because the vessels are longer. This is a patient who underwent laparoscopic donor nephrectomy. This is a left nephrectomy here. You see the port, and there's the small incision to get the kidney out. So it's probably got gas in it still, because it's still a little bloated. And this is the cartoon, so we would do, where are we here? Left nephrectomy, we engrafted the kidney. All right, so what's the surgery timeline? Well, when we do the donor with a laparoscopic procedure, it takes 2 to 3 hours. Their average length of stay in the hospital is anywhere from 2 to 3 days. On the recipient side, the surgery time is 3 to 5 hours. Can be longer than that if they have adhesions from previous surgeries. Their average length of stay is about 7 days, but it's been as short as 2, and it's been as long as many months. This is an actual recovered kidney sitting in the hands of Dr. Ruzek. Here he is sewn in the vessel. Where's my thing here? Okay. This is the ureter he's working on. I don't know if you can see that against the red. So this is the ureter. This is the stent. Stent coming out of the ureter. Okay, this is the dome of the bladder. He's incised it down to the, taking off the top and down to the muscle there. This is kind of hard to see, but this is the ureter now sewn into the bladder. And that's what it looks like when it's all done. So the kidney is hooked to the great vessels that feed the leg, the external iliacs. And the ureter comes down to the bladder, so the patient urinates in the usual customary manner. The kidney transplantation has many challenges. And our greatest is the immune system. How do we overcome that? Because it's supposed to defend us, and a transplant is a foreign object. The role of the immune system is to recognize self and non-self and to kill non-self. Takes it out. An antigen is a molecule that stimulates the immune response. It's actually a protein. There are 2 mechanisms that trigger the antigen. There's cell-mediated immunity, which causes cytotoxic cell activation, which are our T cells, and then humoral or antibody-mediated rejection, which causes antibody production from B cell activation. Here you can see the immune system. It's really complex. It's really hard to manage all that because the body's very clever. So we have an immunology pyramid and a rejection kind of pyramid. So at the base of the pyramid is the antigen-presenting cell. It finds something and it presents it to the macrophage and the lymphocytes. They look it over and they think about it, and if they think that that's something to work on, then they do. Then cytokines are recruited, and then the patient starts having fevers and achiness, and then antibodies are eventually performed or are formed by the body. In the immune suppression side, we use a calcineurin inhibitor. This would be programmed for cyclosporin to try and stop the first phase of the rejection. Cellcept is the second phase. Steroids are the third, and then our induction agent that we use is thymoglobulin. So we put the 2 pyramids together, you can see here. Antigen-presenting cells, cyclosporin and program work on that. Cellcept works on the T cells and macrophages. The steroids work on the cytokines, and the induction agents work on the B cells. The goal of transplant pharmacology is to prevent rejection, but we also have to try and prevent the occurrence of cancer, because when we modulate the immune system, then the immune system can't manage cancers very well. So our biggest fear not only is the opportunistic infection, but the occurrence of post-transplant lymphoma, or PTLD. It's associated with a rise in the Epstein-Barr virus, so it's something that we monitor for. We want to balance everything carefully. We want to give them enough immune suppression they don't reject, but not so much as to develop other opportunistic infections and or cancer. There are 5 major drug classes of immune suppression drugs. There's the calcineurin inhibitors. This would be the Prograf and the cyclosporin. The anti-proliferative agents would be Cellcept. Code for steroids, that's your prednisone. Anti-lymphocyte antibodies, that's the thymoglobulin, and sometimes we use immunoglobulins when we do plasmapheresis to take out antibodies. The risk for using these medications is infections, and they all, of course, have side effects. Some are manageable, some are not. And then there's the worry about PTLD, or the transplant lymphoma. Patients are also at a greater risk for developing skin cancers. The standard of care in preventing rejection is to use a calcineurin inhibitor like Prograf. a steroid, and an anti-proliferative agent like Celcept, and then we use an induction agent that's thymoglobulin. Drug therapies change based on the type of the transplant, a previous transplant history, if they've had rejection, if they've had severe rejection, like antibody-mediated rejection, and any clinical situation. One or more immunosuppression drugs may be held, decreased, stopped based on clinical situations, toxicity, side effects, sepsis. So we have to kind of balance everything, get it right. Reprogramming. We need to reprogram the body's immune system here. We do that by using induction therapy. It's a short course of thymoglobulin. The most I've seen given is 7 days worth of thymoglobulin, but we try and reset the thermostat so that patients don't recognize the foreign body. There's maintenance therapy. This will be the long-term use of Prograf, Celcept, and prednisone. If there is a rejection, we need to rescue the patient. So then we give them more steroids, more Prograf. Sometimes we have to give thymoglobulin again. If it's very severe, then they have to have plasmapheresis with cytogam. High-risk patients are patients who had a second transplant who are getting a dual organ. So if you're getting a kidney panc, you're getting a kidney liver, they're a high-risk patient. If they have high antibody titers, they're previously sensitized either from blood transfusions, pregnancies, or previous transplants, then that makes things more difficult. If there is a great degree of mismatch between the donor and the recipient, which means they don't match at all, it's not that the transplant's not doable, they require more medication. Is there long ischemia time? How long did the kidney sit in the bucket before it was re-engrafted? Like I said, resetting the thermostat here. And we want to prevent rejection, but prevent side effects, infection, and cancer as much as possible. But infections do happen in the transplant patient. We see 3 kinds: bacterial, fungal, and viral. And these antimicrobials are used to try and combat the different kinds of infections patients will see. So for the virals, we use acyclovir, cytidine, valcyte's our workhorse. For the fungals, we can use nystatin or Lysolex. Mostly we use itraconazole now because we're mostly worried about aspergillosis. We're also worried about pneumocystis pneumonia, so we use Septra or Bactrim. Dapsone if you're allergic to sulfa, and if you're allergic to both of them, we have to use pentamidine, and that's really complicated because that's hard to even find anymore. If the patient has tuberculosis, then they're on INH. But despite all of our efforts, rejection still can occur. The immune system is very strong and very complex. So what are the signs and symptoms of transplant rejection? Well, it usually starts with a fever, 100 or more. There may be pain at the transplant site. There's a swelling around the area, and that's what causes the pain. The transplanted kidney itself has no nerve ending, so it can't feel pain, but the swelling of the graft because of inflammation from rejection will push other structures aside, and that will cause the pain. There may be decreased urine output. The patient may gain more than 2 pounds in 24 hours. That's all water retention. They may have edema. They may have a rise in creatinine. Their blood pressure may be difficult to control. If we suspect rejection, we admit the patient to the hospital, redraw the labs just in case. We will do an ultrasound-guided transplant biopsy. The treatment will be based on the findings from the pathologist. Do they have an antibody-mediated rejection, a cell-mediated rejection, or chronic rejection, which we can do very little about. Most chronic rejection, though, they think is really antibody-mediated rejection that's gone on for a long time. When we care for the transplant patient, we need your help in talking with us. What do you see? What's going on? What are the patients telling you? Sometimes they're reluctant to tell the doctor that they're having hallucinations from the medication because they're frightened from it. But if they let you know, it would be helpful if you could let us know. Attention to detail is the crux of everything. Everybody's going to know when a patient grabs their chest and has an MI, but it's the little subtle things that start the dominoes to fall that are useful information. There's nursing resources. We have them on our transplant floor, but if you happen to be on the orthopedic floor, we have an inpatient care coordinator. You can also call our office. We're always available to help with any kind of transplant patient. This hospital does kidney transplants, but we get hearts, lungs, pancreas, liver. I don't think we've had bowel, but we've had everything else. So we figured it out for you. You can take some extra transplant educational opportunities to help build your fund of knowledge. And for those of you who work on a transplant floor, you can become a certified transplant bedside nurse. Any questions? All right, Ms. Kim's going to be doing the question and answer period here.
Hi, I'm Kim Lawrence. Is that on? You hearing that? And I'm the clinical coordinator in transplant, and I'm also the inpatient coordinator. So when our patients get a transplant or if they're readmitted for rejection, then I'm the one that comes to either educate them or to visit them. So what questions might you have? Okay. For the life of that kidney, they are. Yes, they are. And even as that kidney sometimes starts to fail, we don't completely withdraw the medications because that would be rather abrupt, so we taper them off. So yes, they are. Those three medications, Cellcept, Prograf, and prednisone, are the ones we currently use at our transplant center. Aurora? Sorry.
I know it's not normal, but is it common for post-feeding transplant to experience things like blowing, feeling?
Oh, what feeling?
So there's some like explosive all the time, like every time they eat something, they get bloated, and then I do not know if that's the exact side effect of all the medications, all the anti-rejection medicines that they're getting. But my friend just had a transplant like a month ago.
Well, in the beginning period of time, the Cellcept is one that does have abdominal side effects, so nausea, vomiting, abdominal pain, so sometimes that might be it. And usually that side effect kind of goes away. It's like your body needs to become accustomed to that medication, and usually after several weeks that kind of goes away. But I would not say that that is a typical reaction. And we do typically put our patients on Protonics or something like that, BID, because we worry about prednisone and the side effects of steroids causing ulcers in our patients. We usually start with Protonics in our center, and depending on their insurance coverage, then we may have to move to Pepcid or something like that. Okay. What else?
Okay. Our rejection rate is extremely low. When we do have a situation like that, though, the only time I've ever seen a kidney taken out is when we're putting another one in, doing a retransplant. Has there been any occasions, though, where we need to just take that rejected kidney out and just close off the vessels?
Probably you might be able to answer that a little better than me, because I have not seen that done. We typically don't take out transplanted kidneys, and even native kidneys we don't take out. The only time we would do that is maybe the patient or the polycystic kidney disease patient, and those native kidneys are causing problems with the cyst rupturing and loss of pain and or getting in the way of a transplant, but not typically taking out a transplanted kidney. Do you have anything else to add?
So patients who have lost their function, they're actually back on dialysis. Like Kim said, we don't stop the anti-rejection medicines abruptly because they can precipitate an acute rejection even though the kidney's failing. So the medications are tapered over time, but about a third of those patients will still have a rejection episode severe enough that will require a nephrectomy of the transplanted organ. And that will stop that process.
My other question. Okay.
They tell me that they're not having any signs of rejection. What is the typical follow-up for someone who's doing well after?
Our typical follow-up, so there's clinic appointments, first of all, and we have our patients come in every single week for the first several months to see Dr. Ruzix, and then that starts tapering off to every other week. As far as lab appointments, we reserve the right to send our patients to the lab every single day after they're discharged from the hospital. But a typical lab schedule would be a Monday, Wednesday, Friday, so three 3 times a week for the first month, and then it would drop down to 2 times a week in the second month, and continuing down to where Dr. Ruzix always would like our patients to follow up at least monthly with labs, but many times after the first year, we are turning these patients back over to their community nephrologist, and they have their own schedule for lab draws, and I would say most typically what I see is every 3 months, although Dr. Ruzix would prefer monthly.
Right. Where we find the rejection.
Yeah, we just feel that if we can find something early, we can head off some of these rejection episodes. And if it goes 3 months and someone's in a big bad episode of rejection, then it's much harder to turn that around. Yes, Aurora. Usually the first 3 months we have them on, the itraconazole or the sporanox, antifungals, the antiviral Valsite for the first 3 months. So our antimicrobials are typically for the first 3 months, and then we start tapering those. Yeah, we stop those.
My experience is not with kidneys, but I do have some with heart transplant.
Uh-huh.
And I know that post-transplant, we would do biopsies to rule out rejection. And they were in the process of developing actually blood tests that they could to predict the possibility of rejection after the surgery. I was wondering if anything like that is being worked on in their renal bowl.
I don't know about lab tests for that, but I do know that some centers after transplant routinely biopsy their patients on schedules. And Dr. Ruzix feels that he chooses not to do that. We follow our patients very closely. We're following their labs, and we typically see if something comes up. So, and there is risk to biopsy. There's risk of bleeding inside and things like that. So we don't do that. But as far as labs to markers or something to...
well, we follow the creatinine. UCLA was developing a Silex test, which I don't know that really... We don't use it. We tried it a couple of times, but we don't find it useful for renal. I don't know if other centers do. We don't use that. It's different for hearts.
But it is called Silex.
Yes.
Yeah. All right, thank you.
Okay, sure. Anything else?
Yeah, kidney itself have a certain life expectancy. So you put in a new kidney, and you think, okay, this kidney will last 10 years or 15 years, or it can last the life of the patient, or... Well,
all kidneys will ultimately reject. But like that one of the slides that Paula was showing, we would say that a patient typically has 10 years lifespan on dialysis, and across all deceased donor kidneys, looking at every age category and those with and without diabetes, you would get 20 years from a transplant. And I do keep the records in our center for our follow-up. We're required to follow up with the federal government annually on our transplant patients to see if their grafts are still functioning. And I've got patients on the list that are 27 years out and 23 years out. I'm doing forms on them all the time. So it's very dependent. And I would say the biggest reason kidneys fail is noncompliance on the part of the patient. So failure to follow up with their physician, failure to follow up with their labs, and not taking good care of themselves and with their health habits is probably the biggest reason for failure. So I think that, the patient is very capable of extending the life of that kidney with good practices.
That was going to be my other question, was what else besides taking their medications would you coach someone to do so that they could get the maximum life out of the kidney?
Well, one of the big things for us, we see lots of our patient population have skin cancer, so using sunscreen and following up with dermatology, but just, following up with all your good healthcare practices, your cancer screenings and things like that, and sticking to a very regimented medicine regimen, I would say, is very useful for them too, because you start skipping doses of these anti-rejection meds and those kidneys will reject. Anything to add to that, Paula? No? Okay. Anything else? Anything else? No? Thank you. Okay, great. Thank you. I've got to do that there. Yeah. Okay. Take it easy.
My friend Jerry, another friend Jerry, she's RRI, and she donated her kidney to her sister. really blame your sister for not taking care of herself. She didn't feel like her sister had really done a good job of taking care of that kid. So